Welcome, everyone, to today's panel discussion, Achieving Operational and Clinical Efficiency in a Supply-Constrained Environment. I'm Brian Zimmerman. I'll be the moderator for today's session. On behalf of Becker's Healthcare, thank you for joining us. Before we get going here, I'm just going to walk us through just a few quick housekeeping instructions. So you can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. If at any time you have trouble with the audio or video, just try refreshing your browser. And you can also submit any technical questions into the Q&A box. We've got folks on the back end who are available to help. So with that, I want to go ahead and introduce our terrific panelists today. We've got Pete Bennett, SVP Global Planning with Cardinal Health, Carol Pohatsky, Associate CNO Surgical Nursing with Cleveland Clinic, and Steve Marshall, VP Pre-Source Procedural PAC Solutions with Cardinal Health. Thank you all for being here today. I'm going to get going with these questions. So, of course, when the healthcare industry supply chain really derailed in 2020, leaders had to make quick pivots, make adjustments with regards to supplier diversity, better inventory planning, and really building strong collaborative cultures. And that all played a really key role in helping to weather those supply chain challenges. I'm curious though today for supply chain leaders who really want to stay ahead of the curve, what strategies or partnerships should they really be considering to really ensure resiliency and build back against sort of any potential future derailments? Pete, I'm going to tap on you to get the ball rolling on this.
Yeah, thanks, Brian, and really happy to be here with this team. I really think starting from a partnership perspective, you can create a resiliency blueprint that works for both the supplier and for the provider. And in that blueprint, it's a journey, and you really need to look at different aspects of planning that would help to improve access and visibility to supply, but also access and visibility to projected disruptions. And so really starting from Cardinal Health's plan of what a resiliency blueprint looks like, we work directly with the clinic, Cleveland Clinic, to be able to identify areas that were important to both parties. And so really developing a supply plan, a demand and delivery plan, a business continuity plan that was shared very openly with our providers, that all resulted in our discovery and need to help to leverage technology in a different way. And so that led at Cardinal to be able to say, we need an investment in a system, a new brain that'll help us do that. So we really looked at investing in an advanced planning system. We happen to be using Kinaxis, but that allows us and enables us to be able to look at our end-to-end supply chain. So from that very early demand signal from the providers all the way through to what we manufacture, procure, to be able to deliver it in a consistent basis. And when we can't deliver, to be able to come up and problem solve with our providers to be able to see how we can mitigate those different disruptions. Future state, we really got to look at other areas to continue to optimize, to include global trade, our end-to-end supply chain visibility, using and leveraging demand sensing technology, and then third-party risk management systems that would be able to enable just a better, more collaborative conversation between both of us.
And you know, hearing a lot about sort of that culture of collaboration, you know, across Cardinal and at the clinic as well. So, Carol, I would love to hear from you, your perspective about how that partnership has really evolved and what else can be done to ensure resiliency here.
Certainly. Thank you so much for having me. And I'll be frank at the outset that my worldview is very much surgery, all things pre-op, OR, and PACU. So when I think about supplies, we're really focused on the care of the surgical patient. And having said that, though, I think it's really important for supply chain leaders to think about resilience in terms of where their products are coming from. You know, at the point of care, I don't want a surgeon or a surgical team worrying about Hurricane Ian right now, disrupting their ability to care for patients tomorrow, next week, a month, et cetera. And even before the pandemic, we saw natural disasters, other things, plus then a pandemic that did disrupt our ability to get the products we needed to safely care for patients. And so it's all about trust, right? If I don't trust my vendors, my suppliers, then when they say the product's coming, I may make rash or impulsive decisions. If I don't trust them, I might partner with somebody else. I might start hoarding product. I might be doing other things that aren't in the best interest of my organization, my patient, if I don't trust the people I'm working with. And so having that foundation building it, continually building upon it and listening to each other to really understand there are challenges on both sides of things, but really keeping our clinicians focused on the care of the patient and making sure that whatever they need to do that safely is readily available and isn't disrupted by the geography of where the items are coming from or the geography with where the care is being delivered.
Thank you, Carol. So much here about like sort of the trusted transparency and open communication between the two organizations. Appreciate you sharing your experience. Steve, I want to turn to you now and really, looking forward, what challenges and sort of opportunities do you anticipate within healthcare with regards to the supply chain? What's coming down the pike?
Sure. Thanks, Brian, and thanks again for having me. Wow. Feels like there's many challenges right now. I'd say, three really stand out. I think the first being that whether we want to admit it or not, there's going to be ongoing volatility within the supply chain. Unforeseen significant disruptions like new strains of COVID, geopolitical tension, natural disasters. I think as an industry and as a society, we need to realize that there's going to be curveballs and we have to forecast for them and we can't get caught flat-footed again. And, I think it's been super impressive as an industry how we've really rallied together to reactively solve for these problems and do the best that we can. And we've heard, a lot of different stories around supply chain heroics on the provider side and on the supplier side to really get through what we've been through over the last few years. But obviously it's not sustainable and we need to be more proactive with our risk prevention. So I think that's definitely the first one. The second one really relates to the talent crisis and labor shortage, and not necessarily even just on the provider side, but on the supply chain and manufacturing and supplier side as well. On the supply chain side, virtually every supply chain was broken, not just healthcare. And really the supply chain industry is now competing for similar talent, right, to get their supply chains back in order. And supply chain salaries, unfortunately, lag many other industries. So we've actually had people leave this sector to go into other sectors as well because of burnout and the challenges that have been there with supply chain. And then on the provider side, obviously a major issue as well. And it's hindered a lot of the procedural bounce back or so that, we've been expecting post-COVID because we just simply don't have enough people, right? And hospital employment is still down to, where it was pre-COVID and pre-pandemic due to burnout, early retirements, other sectors poaching our talent, and the acute setting is hit really the hardest as well. So, I think these factors combined with the inflated salaries are really leading to increased costs of labor, retention bonuses, as in everyone kind of fights for that same labor. And unfortunately, with these shortages, we've asked our nurses and our healthcare providers to wear a bunch of different hats and go to SPD, help with supply chain management and really do a lot of different things. And it becomes almost a vicious cycle where it's do your day job, care for patients, but do these other things as well. And it just accelerates that burnout that we're seeing. And really another interesting dynamic as well is I think we've seen, people be a little bit more nomadic, post-pandemic, moving around. I have a little bit more flexibility. And what that's done is really increase the amount of traveling nurses that we've seen. Hey, I can make a little bit more money, I can travel around, and it's really made it difficult on the provider side to keep good talent, right? And it creates that cycle of hiring and retraining and trying to keep. But Carol, obviously this is your world. I know you've been living it over the last few years. I'd love to hear your thoughts on the labor challenge as well.
Certainly. And, we're very fortunate. I'm very fortunate at Cleveland Clinic. We've had such great executive support and sponsorship to really think creatively, think dramatically and diversely, and try to consider how we can attract and retain talent when and where it makes the most sense to bring in those travel agency resources, understanding that we're always very thoughtful about who gets to walk through that door and making sure they're living our Cleveland Clinic values and level of care, no matter whether they're employed with us permanently or not. And to your point, it's obviously we're laser focused on registered nurses, surgical technologists, PACU nurses, pre-op nurses in terms of our clinical delivery of care, but certainly it's everyone from the incredibly talented individual who orders the supplies, who puts supplies on the shelf, who checks for outdates, the talented sterile processing department caregivers. We really want laser focused on processing instruments and not pulling items for the next day and doing other things that takes their focus off of what they do best and what we've asked them to do best. So it's very much a push-pull. We want everyone to work at the top of their license or their scope, but in absence of other people to do the things we need to do to take care of patients, it does end up turning into people getting really creative. And as long as they're being thoughtful in that creativity and not, oh no, come back, then we support it. But we also think about how can we acknowledge that, thank that, recognize that, going above and beyond with really an eye towards how can we reach out to our communities, especially for those roles that don't require advanced education or licensure, to really partner with our local communities to create different and new ways to bring folks into healthcare. And I realize maybe I'm moving a little more towards the opportunities than the challenges. But I think that's how we have to look at it, with both sides of the coin, is that we can dwell in this is really a challenge, or we can think about what can we learn and grow from in light of this challenge.
Yeah, the challenges are significant and absolutely can't be ignored, but there's also been so much learned throughout the course of everything that's happened here. So I imagine with those lessons learned, there are a lot of opportunities, Carol, as you were sort of alluding to and getting to. Pete, though, I'm wondering if I could turn to you and perhaps hear what your take is on the potential opportunities here.
I have a ton of opportunities, and a lot of it really starts with collaboration. One of the things that we started to do about a year ago now, so still in the middle of the pandemic, was to create an organization called Collaborative Planning, Forecasting, and Replenishment. And that really does help to align business objectives between the providers and the distributors of the manufacturers. And again, enabled by technology, we're able to do things like demand sensing. So when we're starting to see patterns of overconsumption or underconsumption, we can have those conversations. We're also looking at leveraging different aspects of data. So maybe there's point of use information that we can leverage, even using our own technology at Cardinal of Wavemark, where we can actually say, hey, this is actually what's being consumed. So it's some really great conversations come out of having a team like that, but also really starting to look at what benchmarks we've got across the organization and pulling in partners, true partners, whether it be the GPO or whether it be the health system itself, to be able to figure out how to manage inventory so that we're doing so in an effective manner. That has resulted in different solutions for different providers, whether that be customer-owned inventory solutions, or whether that be bringing in additional inventory because we understand consumption looks a little bit different, or it's higher because of our demand sensing technology. So really, these opportunities to make this alignment between the two organizations is really where I see the most effective way of managing our organizations moving forward, but also the supply. And unfortunately, there's always going to be supply disruptions. We just have to figure out how to manage through them and be more proactive about it, so that the end result is that the patient is not seeing any disruption in care.
Thank you, Pete. And before we move on, Steve, you sort of kicked us off on this thread, talking about some of the challenges here. You did a really concise but comprehensive way, but I want to give you a chance to speak to potentially opportunities as well before we move on. Do you have any additional hook-ons there to what your colleague just shared?
Yeah, absolutely, Brian. You know, I think one opportunity, and it's a challenge right now, but it's definitely an opportunity, is the shift of care. You know, we've seen patients beginning to move in more outpatient settings, and I think over the last few years, we're just going to see that accelerate even faster. And really, I think three different ways we're seeing that. I think we're seeing, you know, highly complex procedures moving to ambulatory surgery centers or office-based lab, lower cost of care. We can get them out faster. You know, physician visits going to more telehealth. I think we're seeing that, and we'll see it accelerate even faster. And then, you know, at home was happening, you know, very frequently prior to the pandemic, and I think we'll see that, you know, accelerate even further. So I think consistently we've been seeing this happen, move to more outpatient settings, you know, more convenient, lower cost of care, and I think we'll see it move even faster. And I think it's just a really good opportunity to rethink, you know, how we're providing that care, and as a supplier and distributor, how are we delivering the products to those care settings where the patients are going to be. And healthcare providers are going to be looking for more just, hey, get my product to a new location. They're going to be looking for solutions as well. how do we think about packaging, storage configuration and redesign, directly shipping, product to patients, or really even better consumer education, right? If we don't have as much time with those patients or they're getting products at home, how do we help deliver better education and take some of that burden off of our provider partners? But Carol, I'm curious to see what you've been seeing on, shifting of care settings in your world.
Absolutely. And, in the earlier days of the pandemic, when we think back to March 2020, certainly where the Cleveland Clinic is in US locations in Ohio and Florida, there were mandates from the governors of each of those states shutting down outpatient care to really preserve that PPE and to really shuttle our caregivers into other places to provide care for pandemic support. And what was really illuminating as part of that is how much outpatient care is being done in a hospital at that time. And so just because it isn't being done in an ASC doesn't necessarily mean it's more complicated. It's providing the level of care the patient needs. And so it's really, as we then continue to evolve past that day to now, is really looking at, independent of reimbursement models and things like that, what is the right thing to do for the patient in terms of the care they need specific to surgery in my world, but also where's the right place for care following their surgery. And we certainly don't want to do one surgery as an outpatient because there's no room in the inn. That should not be the impetus for why we conduct a surgery as outpatient. But if we've been holding on to, but this patient really needs to spend the night because I want to have morning labs that I can check, can we question that? Should we be challenging that to say this hospital bed, especially during the surges in the winter times of 2020 and 2021, really further push that envelope to say there really is no room in the end. So we now are allowed to do outpatient surgery, but we really have to be thoughtful about how much inpatient surgery can we do. We want to provide that patient the best, healthiest outcome and experience, but we have to also make sure that we're prioritizing at that point COVID care as well. So really working with our surgeons, our providers, our nursing teams, everyone who touched that patient to say, what do we need? What could we do to get that patient in a place where they could go home that day? Or they could do 23-hour observation instead of a longer stay with us. And it's really challenged us to let go of some of those, we've always done it that way, sort of approaches, especially to surgery in my areas. We've been able to see, the other great thing is that we've been able to see transition of some of these types of surgeries to an ambulatory surgery center, and then they stay there. That was our concern early on, was when capacity opens back up, will people sort of ebb back to what they're used to? But we really have been able to see, and not just at the Cleveland Clinic, but across the country, more and more of that surgery that should be done in an ambulatory setting being done there.
Awesome.
Yeah, right. It's fascinating to hear about, and very interesting. I think some of the conversations I've had with leaders too is about how you keep the momentum for change going. There was so much transformation that was able to happen because of the pandemic, and how do you folks were able to move faster, do different things, move sites of surgery to ASCs that they didn't think maybe they could do before, but now you kind of know what you can do now, right? And Carol, how do you think about keeping up the momentum there in terms of not letting that sort of the spirit of collaboration, the speed with which you were able to work? How do you think about keeping up that momentum as the pandemic sort of wanes?
I think what's important is to really keep listening to those who are delivering the point of care, right? The surgeons, the nurses, the techs, because we also don't want to burn them out with the speed of change, because that's all we've had for the last 3 years, really, at this point. But to really say, listening to them to say, if we did that outpatient and it didn't go perfectly, why not? And how can we make it better? What do we need to do the next time this is done as an outpatient so that you go, oh yeah, this was totally fine. The good news for us in a weird sort of way is, because we were forced to make some changes, they then became rote almost enough that people have forgotten that we used to do it a different way. So it's really then when the next idea comes up, what's great about being part of a large organization is we can usually turn to somewhere else organization and say, they were able to successfully turn on this program at this site. Let's go talk to them and see what lessons they learned, what things went well, and how we should model that elsewhere to make sure that we're expanding that innovation beyond the site of its creation. One of the things I think about in terms of opportunities as well, that was one of those unintended consequences, I think, of all of this, was when I think about the early days of what was in our surgical packs, for example, or single sterile items on the shelf from Cardinal, is people were really committed and tied to that thing they were used to having. My needle box is red. It has 6 slots on each side, and really attached to whatever that thing was. And when you tried to standardize with a very clinically equivalent product, it turned into a very emotional conversation over something as simple as a surgical drape. And now here we are, where for no fault of anyone, we do have some times where we literally have no choice, right? We have to clinically substitute the blue box for the red box. Our friends at Cardinal have done their due diligence. Our group has done their due diligence to ensure that these are clinically equivalent. There is no disruption in clinical care. This is what you're getting. And initially, in the early days of the pandemic, there were still those conversations where you had to say, yeah, it's going to look a little different, but if you have any concerns using it, let us know, but this should be seamless. And really, it's to the point now where people have let go of some of those emotional attachments. So we're really trying to leverage that to say, again, it always has to be clinically superior, perfect, does exactly what we need it to do, but letting go of well, we always used this brand or this product, and really saying, what is the financially the best decision that is the most clinically standard product we can use across a large organization.
Thank you so much, Carol. I appreciate you going deep there for us. I think attendees will really appreciate some of that. I want to move now to sort of thinking about finances here. No secret that inflation has been a challenge. I'm curious, Carol, if you could speak to your experience about how you've potentially worked to really save money during this current economic situation that we're all in, and really how you're working to perhaps drive optimization and greater efficiency. Can you talk more about that?
Certainly. At the Cleveland Clinic, one of our core founding principles is caring for the organization as if it were our home. And that's always important, but it's really been something we can go back to with caregivers to say, as we're all thinking about our own personal finances and what that looks like, as really being thoughtful about always making sure we're using what we need to use to care for the patient. But the days of bringing in 5 urinary catheters and opening all 5 of them just in case, we really need to think more critically about the items we use, the items we open, to really making sure that it makes sense for the patient. Again, we don't ever want to disrupt patient care, but how we really have continued to introduce that thought to caregivers, that it's a balance, and making sure that we're being mindful of that. And to take that a step further, what we had started pre-pandemic and we continue to work on is thoughtful standardization. So not necessarily across the board saying this is exactly what a knee surgical pack could be, but really thoughtfully thinking about where is that care being delivered? What is the level of illness of the patient? Again, going back to that, just because a surgery is happening in a hospital doesn't mean that patient might be more acute than an outpatient setting, but they might not be. So looking at the CPT code on which it was billed, their criticality in terms of their ASA score, to say this patient's being done in a hospital, this patient's being done in ASC, they're having the exact same procedure. Let's look at the supplies we use. Let's look at the packs we use, and let go of the ASCs have the same products and the hospitals have the same products, to really customize it to the types of patients we're serving and to tier it out that way. And one of the lessons we learned, thankfully, before we turned it on, was in the early days of trying to standardize our packs across many locations, we were looking at how often something was pulled single sterile in addition to the pack. And we found that there was an item that was pulled additionally about, let's say, 55% of the time. And so from a clinical caregiver standpoint, the idea was, yes, let's put this in the surgical packs. It's going to be more efficient for us to not have to run and get it. And yes, 45% of the time we won't need it, but we're very thankful for the 55% of the time that we do need it. Well, we found out it was going to dramatically increase the cost of that pack to an item that we would throw away or repurpose 45% of the time. And so we were able to quickly pump the brakes with Cardinal and our local supply chain to say, all right, time out here. Like we need to make it make sense for everybody in a way that we're not creating inefficiencies in terms of getting the supplies, but also being really thoughtful in the spend that we make. And one of the partnerships that has been really fantastic for the Cleveland Clinic and Cardinal is our use of the Wavemark inventory management system. And so now that we have that in every location, we're able to see item use level data for every surgery in every location. And while we build that database, we don't necessarily have year over year yet in some of our locations, but we certainly do have that level of detail to say, these are the items used on this specific patient with this surgeon. So we can really get to that data to say, is there something different we need to do? Is this representative of, we used to use product A, that spend went to 0, and now we're using product B. So yes, it went from 0 to 100,000, but these are substitutes. We're actually saving money. We did, when we looked at our data, saw this dramatic increase in spend that initially, gives you that gasp moment when you realize they were LVADs. And we're now putting a lot more of those in patients, especially as part of COVID treatment. And so as opposed to doing something different with our clinical care, we realized, yes, this is a larger spend, but it's because we're doing more of this type of care than ever before. And with that layer of data, then we're able to talk to our clinical caregivers to determine if there's behavior changes needed. Just as Steve mentioned, in terms of education of consumers, of customers, we also need to make sure we're educating our caregivers, and products need to be really easy to use. We might have an agency nurse who's spending 13 weeks with us, or we might have somebody we've hired, but we know that they may only spend 2 or 3 years with us in the operating room, for example. So if something's really complicated to use and to learn, we need to be very easy to use so that they understand how to use it. They can be more efficient in their practice. And we need tools so they understand, this is an item I need in the room, but I don't need to open it. So I can perhaps return it to use versus something I need, so that we're not capriciously opening things and being wasteful, so that that new caregiver or that agency nurse who's spending a little time with us can be as efficient in their use of product as somebody who's planning to stay with us for a long time.
Thank you, Carol. Steve, I want to hear from you too on this, but first, another quick follow-up for you, Carol, if you don't mind. You talked about sort of how early on in the pandemic, some of the shifts you made in terms of the supplies that were being used. Folks might have an emotional connection to them, or feel like they really need it. Does having that data you talked about sort of make those conversations easier to have when you're making shifts and changes with folks? Are they more receptive when you come to them with that information and you can really explain the why?
I'm going to answer it with it will. We haven't actually had to pull that data out yet because, again, we've been able to leverage the emotional disconnect from product, that we've been able to make some substitutions in packs without, frankly, anyone noticing or reacting to it because of the current state of supply chain. But as we partner together and we really continue to dig into this thoughtful standardization of our packs, it's so helpful to know that we already have this gestalt climate where there's a little less attachment, and then we have that product to go behind it, so that we can. And I think the other thing it will help us do is, we used to all get into a room and bring 3 hip surgeons and 3 lead techs from orthopedics to say what's in your pack and what has to stay. Now we could do it via Zoom if we need to, but we also have much richer data, so we can really present to that team. We can see, based on WaveMark and the Cardinal list of inventory in your pack, what's being used. And we know, thanks to WaveMark, what's actually being used versus what we're pulling and not using, to really give them that foundation in addition to that release of some of this emotional component.
Thank you, Carol. Appreciate the clarity there. Steve, what would you add on here?
Yeah, so I think given the fact that inflation unfortunately isn't going away anytime soon, and the cost of the products is going to be higher than it has been baseline a few years ago, really focusing on that optimization, reduction of waste, efficiencies is how we're going to partner together, I think, to find those savings. And just a few examples of things that we're doing within our pre-source procedural pack solution business. First is, it's really exciting. We're rolling out this tool called pre-source customer insights, where what we do is we look to optimize pack programs by comparing a customer's pack to a procedural template of what we think should be in a common pack for that type of procedure, say a total knee, or we can compare it to hospitals within the region. We can compare it nationally to really figure out, where do we see packs that are too light? Maybe you're single pulling too many different items and you're running around and you're wasting time and energy. Or maybe you have too many components in the pack, and we can say, is there a reason why are you throwing these away? Why does your total knee have 25 more parts than someone else who's down the street? And then if we can combine that, to Carol's point, with our WaveMark business on exactly what is the utilization, we can be smarter together. Also, we're leveraging Aug Intel with predictive dashboards that are able to tell when a component within a pack might run into a service disruption 3 or 4 months down the road by being really plugged into our supply chain upstream. And then what we can do is leverage some enhancements we've made with our pack manager software to alert the customers and our sales reps 3 months in advance and say, hey, we may have an issue. We have these 3 other options that we feel are clinically acceptable. Are you okay if we switch these out proactively? And we can tell our manufacturing plant we can put it into production and we can never miss a beat. So really, I think partnering together, leveraging technology, leveraging data, and working together, we can be more resilient, but we can't do it in silo.
A phrase you used there, I think we can get smarter together, I think really speaks to something that a general theme throughout this conversation, right, which is that collaboration, that partnering. And Pete, early on in our conversation, you really brought that up, just how important collaboration is. Can you talk more about that perhaps at this point? Can you maybe even share a specific example about how collaboration with a strategic partner really played a role in helping hit a clinical goal or an operational goal?
Yeah, no, absolutely. I think it really did start with that team that we built that I mentioned earlier, which is the collaborative planning, forecasting, and replenishment organization, which really gives a planner that works for Cardinal Health the business intimacy to understand what's going on at the provider. So at the Cleveland Clinic, we were able to look at ways that we could substitute clinically relevant subs into their network so that it would build resiliency across the whole continuum of care. So when we were looking at various materials that had high probability of a service interruption using some Aug-Intel and some other machine learning that we had, we were able to say, you've got a lot of risk in this space. Can you look at potentially looking at a substitute here? What happened is we stopped looking at what traditionally happens in the industry, which is your adjusted service levels. So a lot of distribution companies will back out any manufacturing back orders. Well, it's really great. Everything was on back order, right? Everybody knew that. So giving the clinic, it's, a 98%, 99% service level, which 10% of that was actually on back order because it was from the manufacturer, doesn't really help the clinician and it doesn't help the patient. So we stopped looking at it. And we started looking at only unadjusted service level. And by doing that, we were able to start to prioritize what was the most important to be able to communicate between the two organizations, develop a business intimacy that existed on the Cardinal Health side so that they would know. And now I can go to that collaborative planner and say, hey, what's going on with Cleveland Clinic? It looks like there's some materials that may have a disruption. They're like, oh, we already know. We have a solution in place. In fact, we're moving inventory already. They'll help support them. And so whether the clinic will end up accepting that sub or not, we're at least moving that way. And then, well, there's some things that need to be sorted, especially if it's a new material or a new supplier that needs to be validated for them. But it's really been a very rewarding relationship, but as well as a way to actually improve outcomes faster and mitigate those disruptions before they happen.
Thank you, Pete. Carol, can you share some thoughts here based on your perspective?
Yeah, and I want to talk about WaveMark before I get there, I also want to talk about how reassuring it's been that if we have had less than positive experience with the clinical sub, right? On paper, it looks like it should be a 1-for-1 and it gets into somebody's hands and it just doesn't, for a valid reason, not do what we need it to do. It's been a great partnership where we can give that feedback almost instantly and somebody's already working on, okay, cool, we'll get you something else. And it's certainly obviously something is inferior, we're able to get it off the shelves and get a replacement and quickly. And when I think about the email chains from 2019 and prior about there's a back order coming, what do we do? Or I'm looking at a shelf and it looks like it's going to run empty. Those could take days and weeks to resolve. Now somebody lobs out hey, I'm worried about this product getting lean on my shelf at Cleveland Clinic location A. Before we even talk to Cardinal, because we have WaveMark, which we'll talk more in a second, our materials managers can look and say, we've got plenty of that product at Cleveland Clinic location B, and we will get it to you. So we're able to manage our inventory internally with that system in a different way than we used to before. But with the WaveMark partnership, I've participated in the journey, I think, for about 7 years. And it truly has been a partnership between the Cleveland Clinic and Cardinal. Yes, it's an inventory management system, and so that's very important for all the reasons we need an inventory management system. But for me as a nurse and the leader of nurses, what has really made it stand out to me is our ability to deliver safer patient care. Items that are going to go into a patient and stay there. We used to call them implants. I know they have FDA categories now, but those things, I'm getting a knee replacement, I'm getting an ear tube, something's going to go inside of me and it's going to stay there. We have to be able to document with perfect accuracy what it is, which patient it's going into, and making sure that its continuity throughout the supply chain has never been interrupted before we put it into a patient. So it provides our materials management caregivers, as well as our nursing leaders, visibility to it sitting on a shelf. It has a unique RFID. If it's getting ready to expire, we get alerts, so we can be thinking about, are we going to put that into a patient in the next 7 days, the next 14 days, the next 30 days, or do we need to work with a supplier to do something different? Is there another Cleveland Clinic location where that item could be used safely? Because the last thing we want to do is put something inside somebody that isn't in perfect condition. So it provides us that visibility before it even gets to the operating room, so we know it's not expired. But it also provides us the point of use mechanism for documenting it, so we can, with the scan of the RFID, there's no worry about transposing numbers on a barcode or what have you. And so it's going into our electronic medical record that Carol Pahatsky received this unique identifier implant, and if heaven forbid down the road that implant gets recalled, we're able to run a queue and we can very quickly see any patients who are impacted and contact them right away with what the next safe steps are for them and for their providers and their care. And so that gives us, it gives our nurses, our surgeons, this just greater level of safety net that says, I've got this machine learning and this technology working for me, and I don't have to think about it. I just have to wave something in front of a brick and it's going to help me deliver care. It's going to help me document more efficiently. So I'm spending less time doing that as a nurse, but it's that safety net that says, as long as I work with the system, if I try to swing something by that's expired, the screen goes red and I get a blip and there's an alert right away that all the Swiss cheese holes have failed. But here we have that one last stopgap that says, stop, you're not doing the right thing for the patient. So for me, that's an added benefit. And that really came out of Cardinal really interacting with us and learning and really talking about how can we have this be an inventory management system that makes care safer.
Thank you so much, Carol. And I want to close here with our final question before we move to some audience questions, with a question about that's really focusing on those clinical teams that you were just talking about. And this has sort of come up a bit already, but I want to zero in here. And can you talk a little bit about, Carol, how you can continue to motivate clinical teams at a time when, staff shortages are rampant, burnout is such a problem, obviously, and other pandemic related challenges, all these existential stuff going on here that it can be a real stressor. Can you talk a little bit about how you can keep teams motivated, and then also how hospitals and ASCs too can really stand out in this market to attract and retain talent as so little of it is available, really?
Sure. And for clinical teams, it has looked different for different specialties throughout the pandemic. And so with my lens being peri-op, the reality has been for our clinical caregivers is that when surgery is suspended, we find ourselves going somewhere else to provide care. And that is often a place that is less familiar to us. It's flat out scary to us. And as an organization, we've worked very hard to prepare our caregivers with the right learning they need and the right redeployment assignment that meets the best match to their clinical skills. But it's still scary. I'm used to coming to an ASC and delivering surgical care, and now I'm going to a COVID unit, or I'm doing something different than is sort of what I signed up for. We hear sometimes, I didn't sign up for this. And so how we genuinely listen to them, help them get that trauma off their chest, that yes, we've asked you to do something that's entirely different than what we hired you for. Or those caregivers we've welcomed during the pandemic, they're not really sure what they signed up for. And sometimes they get to be at home in their specialty, and sometimes we have to ask them to go elsewhere for the greater good of our community. And so how we've gotten better each time we do it. I sure hope we don't have to do it this winter too. But how we really listen to them as we're asking them to go do something different, acknowledge that yes, you're contributing to the greater cause here. And we always want you to be safe and support, and here are the resources and the educational tools and all those things. So as you leave us in Peri-Op and you go somewhere else, here's all those resources, and there's people checking in on you, the local managers checking in on you, your managers checking on you to say, what do you need and what resources can we provide as an organization in terms of support so that you feel supported. And when those teams come back, how do we celebrate that? How do we reignite their passion to say, welcome home. We're so glad you're home. There's a ton of surgical patients that can't wait for your care. Let's refresh some of the skills that we need to make sure are core to what we do. And this past January and February, it was fun to see at one of our ambulatory surgery centers, the surgeons all bought cake and they took it upon themselves to put banners on the walls to say, welcome back to their teams, because they were all just so excited to get back to doing what we love best, which is taking care of surgical patients. So really celebrating that reuniting, and when it is time to go apart, really supporting them throughout that. And we hope we've moved past that. But so now we're in 22, where sometimes the running joke, even across Peri-Op locations outside the clinic, is, well, we're in our own surge now, and there isn't necessarily a redeployment to come help us, right? We know there's lots of patients who didn't get surgery in portions of 21 and 22 that need surgery now. And doing everything we can, working with our surgeons, with our administrators, with our scheduling experts, with everyone who touches that surgical patient to say, how do we get them in the doors? How do we optimize them for care? Because they may be sicker now than they were when they should have had surgery. And so really, amidst all of that, how do we keep that clinical team going? And so it's all about really being transparent, and authenticity is something we all should be doing, but it's so important now more than ever. It's okay to say to your teams, I don't know what the answer is. I want to hear what your current state is. If you have thoughts, I want to hear them. We're going to get through this together. And really, as we're hiring more caregivers, it creates a burden for the ones who have stayed, right? I'm precepting more, and now I'm precepting this agency nurse, and it can be aware. So really trying to balance out, what we're asking our clinical caregivers to do while we're asking them to sometimes take care of record volumes of patients, and really stretching the day longer, and the other things we're trying to do to welcome all the surgical patients we can. One of the things that we've had some success with here is talking to our agency nurses to learn from them. What should we be proud of at the Cleveland Clinic, right? They're a great secret shopper for us. They've been all over the country. They've been Peri-Op nurses for some of them a couple years, some of them for many years. Some of them have been in the traveling game since before any of this happened. And sitting down and talking to them about, what else have you seen out there in the Peri-Op community? What should we be doing differently? What should we celebrate and never let go of because it makes us special? And so it's been really gratifying to hear from them, and to share with our caregivers who are employed here, to say they're by and large coming in and saying, I love working here. I feel very safe. I feel very supported. Your products, your processes, your policies help me deliver safe care. And when the opportunity presents itself, if they ever want to join the Cleveland Clinic family, we certainly welcome those folks in. But really, it's all of those things that we can do to help our caregivers feel acknowledged and praised. Obviously, money speaks too. And so we're very, very fortunate at the Cleveland Clinic, where we've made major investments into our caregiving force in terms of wages and adjustments to the benefits package. And we're actually right now, or we just finished a survey of all of our caregivers, asking them what they want out of a benefits package. Are there different things we can do to uniquely brand ourselves among, a limited amount of supply for all this demand of labor force? What can we do to continue to meet our caregivers, or our potential caregivers, where they are in terms of not just salary, but also the other things we could offer uniquely to them to help attract and retain.
Appreciate you sharing that. And yes, fingers crossed for a COVID light winter for clinical teams everywhere, and for all of us, really. So I really, really, truly appreciate you sharing your experience. Steve, Pete, before I move on to audience questions, was there anything you'd like to share?
No, I'll just jump in. I mean, everything that Carol was saying, it really just resonates with me, that there's this new relationship between clinicians and logisticians that just didn't exist in a real formal way before. And now just hearing that, the efforts that we're doing are actually yielding results, but also taking some of the pressure off of the clinician in a lot of ways, it just really resonates that we're on the right path together. and that it could not be done without that partnership. So it's a new marriage, but it seems to be a beneficial one, and I'm appreciative of the relationship there. So
Well said, Pete.
Excellent. Okay, let's dive into some audience questions here. As a reminder, folks, you can submit anything you have to ask into that Q&A box on your screen. The first question we'll take actually is a really nice addition to where we left off with the conversation, which is, again, it's about burnout, but not just staff burnout. The attendee writes, it's not just staff experiencing burnout, it's leaders too. How can we avoid burnout so we and our teams can operate at max capacity? Carol, you want to speak to this a little bit? Then Peter, Steve, I welcome any comments from you too.
I'll do my best. And it's certainly, when you think about things that keep you up at night, this is one of the things that keeps me up at night is how can we continue to support, recognize, and encourage the frontline leaders, whatever that title looks like in your organization and wherever you work. Obviously it's healthcare, but it's all of us, right? Is we have a workforce that is challenged, that we're trying to get them excited about their why, what charges their batteries, why do they keep coming back to surgery, for example, especially when they've left and come back, what makes you excited to be back? Why did you join our specialty in the first place? But really helping our leaders and ourselves really tapping into what is our why and how do we keep our batteries charged, because it can be exhausting, right? And there are times we look at each other and say, well, how are you doing? Well, I don't know. How are you doing? And I think part of it is in this world where a lot of us were used to working in organizations where we could sit across the table from one another and didn't have this modality, is how we use this modality to our advantage to stay connected. And if distance and safety allows, trying to reconnect physically in person where we can do so safely. There's just nothing like it, right? There's nothing like being able to, we were able to have an in-person meeting yesterday, and my batteries are full. I was able to recharge for 8 hours yesterday in a fantastic in-person meeting where I was able to see people I haven't seen in 2 years. And so where it is safe to do so, can you start creating those opportunities so leaders can connect with each other? But in absence of that, one of the silver linings for me of this pandemic is that because this modality that I didn't use much before the pandemic, I'm able to connect with leaders in Cleveland Clinic, Florida, in Cleveland Clinic, London, in Cleveland Clinic, Abu Dhabi, in ways I certainly couldn't do before. And so I think it's so important for leaders of leaders to be looking over those shoulders and saying, how are you doing? Because they're getting a lot of it, right? They're getting the, what do you mean I can't start the OR now? And what do you mean I don't have the stuff? And the caregiver saying, I have to precept again. They want to be fixers and doers and to make it all okay. And they can't fix it all. And so how, if you are a leader of leaders, how you can help that individual really think about what are you an expert in and where do you need to tag in some help and how I can help connect that person with that resource. When we, as a mentor of mine once said, when we dabble in an organization, we put it at risk. So I have no business creating Excel spreadsheets and pivot tables. But if I need one, I know that I can turn to somebody in the organization and say, here's what I'm thinking. Can you help me with that? And so how we help those frontline managers and leaders tap into other excellent resources that are going to get it done more efficiently with more skill because that's their expertise. So they can say, that's a great idea. I'm going to tag in so-and-so to help. And then I think it's really all of us, and again, those of us who lead leaders, maybe helping others in this space, is how we create boundaries in a different way. And the challenging part of people working from home, people working hybrid, is that sometimes those days get longer and longer and longer because you're at home. There is no commute anymore. And I can slap a Teams meeting on somebody's calendar and boom, we have access, versus saying, whether I'm in a corporate setting or in a clinical setting, what are those boundaries that I need as a leader so I can go recharge my batteries? Because if I'm depleted, if I'm exhausted, I'm no good to you. And I'm a better leader, I'm a better servant leader if I'm ready and excited to help you in whatever way I can. And so with those new leaders, especially in a mobile world, coaching them through talking to their teams about, if it's an emergency, of course, call me 24/7. But take a breath and think about, is this an emergency? Is this can I talk to you in the next 4 hours text, or is this an email? Because if it's about something that's going to happen in 3 weeks, a phone call at 3 a.m. is probably not appropriate. And so really helping people, just because they have access, taking that beat to think about, there's a human on the other end of that line. And if that's my manager, if I deplete them, then I challenge them to serve me the best way I need them to serve me.
Yeah, Carol, you bring up great points. Just to add on to a couple of them. bringing people together, I found brings so much energy to me and others. And I think a lot of times people don't even realize they need it, right? They're maybe in a comfortable spot, and then you bring them together, right, to celebrate a success or whatever, a networking event or a volunteer event. And then people say, I didn't even realize how much I needed to come together, and I have this new sense of community and energy. So I think that's a great one. And then as a leader, when we talk about work-life balance, because it has been blurred, right, over the last few years, and I don't think it has snapped back as easily as maybe we thought. Like, we're still trying to figure it out. But as a leader, you have to actually practice what you preach. You can't say, go out to lunch, take coffee, take your PTO, and then be firing emails off at 8 o'clock at night or 5 in the morning, or never take vacation, because they'll just follow you and do what you're doing. So you actually, as a leader, have to practice what you preach, or it's going to trickle down and everyone's going to be stressed below you within the org.
If I could just add one little thing in about manufacturing and how we conduct our plan. Again, getting better with business intimacy at both the provider, but also with our own organizations, the team can start to get ahead of things. So there's always the need, and there will always be a need to put out some fires, but that is what just burns out logisticians incredibly. And so having a good plan and a business process in place with resiliency in mind allows us to get way ahead of those disruptions. So we can see things on the horizon. We plan now 2 to 3 years out with our volumes rather than, you know, a 3 to 12 month horizon. And that's important because now we're seeing longer lead times for raw materials, or we're seeing the need to get into relationships with 2 or 3 suppliers so that we can, again, be more resilient. So really having a very clear business process, having a good resiliency blueprint, and then having a really strong S&OP process that incorporates the provider right into it. And that's how we do it with the collaborative planning team. We're able to essentially elevate the business intimacy, but also be able to get way ahead of disruptions before they are impacting the clinicians and the patients.
Appreciate you all weighing in there. Some really some specific stuff for sure, but also some universal stuff that really can be embraced across a lot of industries. Steve, your comment about when you take PTO, really take PTO, definitely resonated with me. You got to be disciplined
Right.
when you're doing your own self-care, right?
Yeah, sure.
Appreciate that. Okay, so let's jump to another audience question. This attendee writes, should I look for a provider that manufactures in the US? Or if not, what should I look for? Peter, Steve, you want to tackle this?
Yeah, I'll grab that one, Brian. So I think it's deeper than that, right? I think geographical diversification and maybe shortening that supply chain lead time has its benefit. But I think you need to be really asking more questions than that. And where you make a product or your geographical diversification, I think is just a piece of that. So as Pete mentioned, having a more resiliency blueprint and reaching out to companies or partners that can really help you build that, I think is key. And maybe an output of that, you know, would be to source or manufacture something in a particular location, but really it's a global supply chain and will always continue to be. So I think that's one piece of it. But, you know, as you think about you know, being vertically integrated, or thinking about where your raw materials come from, or having redundancy, or having systems to trigger red flags of things that could happen. You know, I think it's a little bit more all encompassing than just, you know, where you particularly make, you know, one product or one location. Would be, Pete, I don't know if you have anything to add to that.
No, I mean, it is exactly that. I think that when we think about the various forms of manufacturing and inventory management strategies that we have, there's always going to be a global supply chain aspect to it. And it's really how you manage the inventory that you have available, but then how you're also managing your suppliers and your overall network that builds that resiliency. And so, you know, whether it's close to home here in the United States or whether the manufacturer ends up being overseas, if you have a good resiliency framework, again, you can start to mitigate those disruptions just through that overall business process. So it's really, for me, it's about building better business processes rather than just throwing 400 days of inventory at a problem, because that's just not a sustainable way of managing inventory. And it actually sets the system up for some risk.
Thank you both for weighing in there. And the next question we have is also sort of geared toward the Cardinal team here. So the attendee asked, what concerns are big health systems coming to you with, and what resources are you providing for them?
Yeah, I mean, right now it's still inventory management, and it still continues to be how is Cardinal Health going to leverage the inventory that we have access to better perform. Again, we switched our mindset a couple of years ago, right in the middle of the pandemic, from an adjusted service level where we were backing out manufacturing back orders to an unadjusted service level. So every miss is important, and every miss means we're going to start looking at ways to help to make that product available. And so really looking at adding those resources, adding the collaborative planning, forecasting, replenishment planner that again creates their Cardinal Health badge, but they are advocating very much so for those providers and for those clinicians so that the product is available in their network. And then creating plans to be able to mitigate against disruptions. We're about to hit flu season, and we understand from all of our clinicians that we've talked to, it could be a really bad flu season. And so we immediately started to deploy inventory into the forward network and started to put a little buffer in there so that we can get ahead of what we are expecting to be a pretty strong season, notwithstanding COVID and any other disease state that may continue to rise during the next couple of months. But that's all done with that communication and that internal advocacy, and then some tools, some really cool tools like demand sensing and leveraging Intel and machine learning. But really does go back to just having the right conversations and to be able to provide solutions from an inventory footprint perspective before events happen.
Excellent. Thank you, Pete. And we've got time for just one more quick question. And the attendee is asking if there are any additional resources you can share on achieving supply chain excellence and resiliency. Peter, Steve, anything additional you can share there before we sign off?
Yeah, I'd say, definitely please go visit our Presource website. The things that we're focusing on that we're being asked right now are reducing that waste, and helping find efficiencies. And, as a PAC provider, really that's why we got into business, 30, 40 years ago, was to do just that. So we have a lot of resources on, what we can do to help provide some recommendations, tools, data. We have, clinicians and logisticians that are available, would come in and help review your program to find ways to drive that optimization and reduce waste. And a lot of that information can be found on our website.
And then for me, we really have just launched our Cardinal Health Beyond series, which helps to identify what the supply chain of the future looks like from a Cardinal Health perspective, and incorporates all of our businesses that can help you achieve, and any of the providers achieve, what they're trying to mitigate through disruptions, and what it means for a clinician on how we're going to continue to plan for the future. And then there's also our supply chain center. So again, you can go to the Cardinal Health website and you can find how we operate from our medical distribution and our product offerings so that we can, again, be more resilient, create plans and business processes, and then partner to be able to mitigate those disruptions in the future.
Thank you, Pete. Thank you, Steve. And thank you, Carol. It was a wonderful discussion. It was my pleasure to help facilitate it. I also want to thank Cardinal Health for sponsoring this webinar. To learn more about the content presented today, everything we discussed, please do check out the resources section on your webinar console and fill out the post-webinar survey. We definitely appreciate your feedback. Thank you for joining us. We hope you have a wonderful day.
Great. Thank you.
Thanks, Brian. Thanks, everyone.